Controversy to another. Diabetes, as you know, is a very controversial topic. So I invite Dr. Shalini Jaggi, also from Delhi. She's from the same place as the previous speaker. So she'll be dealing with oral medications during pregnancy. As you know, even now the standard textbook teaches that the compelling indication for insulin is pregnancy, diabetic ketoacidosis, stroke, MI, etc. So let us listen whether there have been any changes in the recommendations regarding OHAs in pregnancy. Over to you, madam.
So good morning, everyone, and thanks speakers for that warm introduction. So what I'm going to do in the next 15 minutes is take you through all the different controversies that we have in terms of prescribing drugs in pregnancy, because this is a very, very crucial phase in a woman's life. And we know that your decision is going to impact not only the mother but the baby as well. So just to inform you, nowadays we use an umbrella term called hyperglycemia in pregnancy given by WHO and FIGO, which encompasses all the different types of dysglycemias that you see in pregnancy. On the one hand, you have pre-GDM, which is women who already have pre-existing type 1 or type 2 diabetes or any of the other form of diabetes. Before she gets pregnant, she knows about it, she tells you I have diabetes, and this is when she's either planning a pregnancy or she's come to you in a pregnancy. Now, diabetes in pregnancy is pregnant women who were not aware that they had diabetes before conception. They have already conceived and come to you in early pregnancy, and you've done a glucose detection test and you've discovered that her hyperglycemia is in the range of overt hypoglycemia as defined by WHO, which means a fasting which is more than 126 or a postprandial which is more than 200. So this is now named as diabetes in pregnancy. And then you have gestational diabetes, which can occur any time in the pregnancy. Earlier we thought it occurs only in the second trimester or third trimester. Now we have a category of something called EGDM or early gestational diabetes, wherein you are picking up dysglycemia in early pregnancy, but you rule out overt diabetes, clearly knowing that the woman does not have overt diabetes with an HbA1c which is definitely less than 6.5. So when it comes to what do you prescribe in pregnancy, if you look at the oral drugs, you need something which either will not cross the placenta or something which is crossing the placenta but does not cause fetal harm. So it is not going to lead to fetal hypoglycemia, hyperinsulinemia or any kind of teratogenicity. So let us look at the different anti-diabetic drugs that we use for our patients and see whether any of these can be used in pregnancy. Well, sulfonylureas, we have been using them for decades now. They cross placenta and have been associated with neonatal hypoglycemia. Earlier, glibenclamide or glyburide was used in pregnancy, but now we know that the cord blood levels of glyburide are almost 50 to 70% of maternal levels. Glyburide has been associated with increased rates of neonatal hypoglycemia, macrosomia, raised neonatal abdominal circumference. It was non-inferior to insulin. Eventually, women fail and they need insulin. Long-term safety data is lacking, and as of today, all global guidelines tell you not to use any of the sulfonylureas in pregnancy. There's no major data on any of the others, so you need to stop them. Alpha-glucosidase inhibitors, only 2% is absorbed as an active drug. High doses have not to be found teratogenic. There are now a number of case reports and studies where acarbose has been given in pregnancy, because we know especially in gestational diabetes where postprandial hyperglycemia is a concern, acarbose has been given off-label. None of the guidelines as of today recommend using acarbose in pregnancy, but it seems to be a promising candidate in GDM. Of course, GI side effects with all these drugs are very common, so you need to be very careful if you are prescribing this. As of today, most of the global guidelines are silent till we have more data on use of acarbose in pregnancy. Glitazones, again, they cross placenta, and animal data has shown embryo-fetal toxicity. So clearly, these are drugs, again, which are not recommended in pregnancy, and you need to stop them if your patient is already taking a glitazone even before she plans a pregnancy. Gliptins, again, all the gliptins taken together a few case reports, because you cannot really do RCTs in pregnancy. That is the biggest problem. So you cannot do an RCT, so all you have to rely on is in the evidence that you have and the case reports that you have. So case reports have shown gliptins also are not recommended. There have been embryo-fetal toxicity reports. Sitagliptin registry also showed some amount of complications in pregnancy. So clearly, none of the gliptins are approved in pregnancy. Meglitinides, ripaglinide and natiglinide, there is very limited data, just a few case reports if you go through the literature. No major toxicity seen, but like, again, since you do not have any major studies, so clearly not recommended in pregnancy, to be on the safe side. SGLT2 inhibitors and GLP-1s. This is the era of GLP-1s and this is the era of SGLT2 inhibitors. Again, of course, you cannot do an RCT, so no major studies that are available as of today on use of these drugs, but few animal studies have shown GLP agonists affect fetal weight, growth and skeletal ossification. Animal studies have shown SGLT2 inhibitors cause dilatation of the renal pelvis and tubules of the kidney when used in the second and third trimester. And additionally, a few case reports have shown unfavorable results. So both animal studies also show that SGLT and GLP-1 agonists are excreted in breast milk and can affect growth. Human data sadly is lacking. So at present, if you look at the evidence, clearly both GLP-1 receptor agonists and SGLT2 inhibitors do not have safety data, do have unfavorable outcomes, especially in animal studies. So clearly they should be avoided in pregnancy as well as lactation. And if you look at the prescribing information, GLP-1 receptor agonists should be stopped at least 2 months prior to conception if the lady is already taking one of these drugs. Now metformin. The most controversial but the most accepted drug in pregnancy. I think our obstetrician colleagues swear by use of metformin all through pregnancy. Now metformin we know readily crosses placenta. However, it has been found to be non-teratogenic. We know it is excreted in breast milk. However, no metformin was detected in breastfed infants' plasma, and we have not seen any adverse effects in the breastfed infants whose mothers were taking metformin during lactation. MIG study was a landmark study that established the use of metformin in gestational diabetes. It was found to be safe. No major adverse neonatal or fetal outcomes were seen. However, few studies have shown a lower risk of neonatal hypoglycemia, less maternal weight gain. So gestational weight gain is less if the lady is put on metformin, but a signal for prematurity and even small for gestational age, which I will show you. So this is a meta-analysis comparing metformin versus insulin, clearly telling you no major excess fetal or neonatal complications in the metformin group versus the insulin group. So clearly, MIG study, I told you, no difference in composite primary outcomes was seen in women who were diagnosed with gestational diabetes beyond 20 to 33 weeks of pregnancy who were given metformin. However, we know that as the insulin resistance of pregnancy increases, there is a need for insulin because glycemic control has to be very tight, and therefore in addition to metformin, insulin may have to be used. Metformin does show reduce in gestational weight gain, especially in obese women where weight is a huge problem. So there metformin can be a good choice. Metformin has been shown to be better in terms of reducing both maternal weight gain during pregnancy and the frequency of PIH in a number of studies. However, few studies have also shown whether it can be used to prevent preeclampsia, but most of the studies as of today show that no major benefits were seen in terms of either preventing GDM or reducing PIH or preeclampsia. But definitely, what you can see is large for date infants are much less in women who are given metformin. However, like I said, a number of studies have shown more preterm births, and this is again been investigated. Another point of concern in metformin that was seen in a few Western studies was that the children who were exposed to metformin intrauterine, when they were monitored after birth, at 18 months, at 2 years of age and beyond, at even 9 years of age, a slight predilection towards having a larger skin fold thickness, larger waist circumference, increased weight-height ratio, BMI and triceps was seen. So children tended to be a little heavier, but they are still being studied. Same again in obese pregnancy, I told you, although the conversion to GDM was not really seen, it was not able to prevent GDM in obese women. However, gestational weight gain was definitely less. So these are the studies. Same for PCOS, because we use metformin for ovulation induction. So usually our obstetrician friends, they want to continue metformin in PCOS women. No major harm seen, but of course, few studies showed that it was able to prevent GDM, but a large number of studies showed that it really did not prevent GDM. So you need to choose the right patient if you want to continue metformin. So these are all the different studies, the PregMed, PregMed2 and the pilot study. So a lot of literature of late has emerged on the safety of metformin in pregnancy. MITI trial came a few years back, which was women with type 2 diabetes who were given metformin alone or metformin along with insulin. Here also clearly metformin treated women and their infants showed several benefits: better glycemic control, reduced insulin requirement, less gestational weight gain, fewer cesarean births. However, a small signal for gestational age was seen in these infants. Now these children who in the MITI trial, the children who were born to mothers enrolled in the MITI trial were followed up for 24 months to look at their anthropometric parameters and their BMIs. Again, no difference was seen between groups in the mean BMI Z scores. So clearly, metformin did not really show any major obesity predilection in these children. Anthropometrics were, however, similar in the children exposed to metformin in utero, reassuring that metformin may be a safe choice, especially in women who have a lot of insulin resistance, who are needing very high doses of insulin. Maybe there, and adding a metformin probably towards the last trimester can help you, reducing the insulin doses and reducing the gestational weight gain. Again, moving on, most of the guidelines today have reviewed metformin in pregnancy. It has been considered first line by several authorities, including FIGO, and I'll come to that in a little while. However, as of today, most of the guidelines currently recommend use of metformin in settings where insulin has logistic or compliance issues. So, ADA clearly tells you that women with GDM who need pharmacotherapy, but due to cost, language barriers, comprehension or cultural influences cannot take insulin safely, maybe there amongst the oral agents, metformin can be a choice, but you need to discuss the known risks and the need for long-term safety data in the offspring. However, important is where you should not use metformin, clearly. A, if there is any growth restriction or acidosis in the setting of placental insufficiency. So if uteroplacental flow is less, those kind of scans which show you that the child is having a predilection towards small for gestational age, liquor is less, weight gain is less, or the mother is losing weight in pregnancy, there you should immediately stop metformin. It should not also be used in women with hypertension, preeclampsia, or a risk of IUGR. So clearly you should not use metformin in these particular pregnancies. DIPSI also says that a pregnant woman who is not willing or cannot take insulin, metformin may be recommended, can be started at 500 milligrams twice a day to the, can be increased to the maximum tolerated dose of 2 grams per day. And however, if she is still not controlled on metformin with MNT, definitely insulin has to be used. So a lot of data on use of different oral anti-diabetic agents in pregnancy is fast emerging. This is again a very recent study that a Nordic register-based cohort study that looked at metformin versus insulin, where it was given right from throughout the pregnancy, all 9 months. In women, no major congenital malformations were seen in pregnancies exposed to metformin, clearly telling that it is safe. No cardiac malformations, no neurodevelopmental defects were seen. Again, this is a CLUE study, metformin in pregnancy, looking at the large long-term outcomes, adverse outcomes. So clearly, exposure to metformin in addition to insulin was not associated with any increase in long-term adverse outcomes. However, a small signal for gestational age was again picked up here, which is still under investigation. However, we know that patients do tend to fail on metformin, especially as the pregnancy advances because of the diabetogenic stress of the hormones in pregnancy. So clearly, you should know when to start insulin. If dysglycemia is majorly high, which means fasting is exceeding 110 or postprandial is more than 140, immediately you should start insulin. No need to try with metformin. Early detection, if you're picking up dysglycemia in early pregnancy, this is a case where insulin should be started early. A woman who's got older age, who's obese, elevated BMI, a high risk pregnancy, renal hepatic dysfunction, history of major congenital anomaly in any previous pregnancy, somebody who's coming with polyhydramnios, or if you have signals of maternal fetal distress, hypertension, preeclampsia and IUGR, that is where insulin should be given. So clearly metformin safety is fast emerging in a number of studies as you see, and that is why FIGO says if lifestyle modifications fail to achieve glucose control, metformin, even glyburide is recommended by the NHS, by the UK. But we know that UK is a very conservative treatment society. So their cost is a big issue, so maybe glyburide is still on their list. But otherwise, globally, none of the guidelines today talk about using glyburide in pregnancy, so it has to be insulin or metformin. This is the GDM, this is the DIPSI guideline. I happen to be one of the co-authors there. So clearly in DIPSI, we've said in the Indian experience, if your obstetrician colleagues have been using metformin for years on end and no major side effects are seen, so metformin may be continued throughout pregnancy. However, if you see prematurity, you should stop metformin, and if insulin is needed in high doses, metformin may be used as an add-on drug to reduce the insulin resistance. MOMPOD was again one study in pre-existing diabetes or GDM in early pregnancy where metformin was given, and clearly maternal hypoglycemia was less, neonatal fat mass was less, maternal BMI was controlled. So clearly no major adverse events, and it was found to be safe. This is another meta-analysis showing it was safe, and this is Indian study. I'm just finishing in a minute. Long-term impact on offspring. This is Dr. Yajnik's group. They followed up children exposed to metformin in utero for about 5 to 11 years of age and clearly showed there was no major side effect, no major adverse event when compared to the insulin group. So clearly, the Indian CDSCO has also now recommended that metformin can be safely used if clinically needed. It can be considered in pregnancy and even in the periconception phase as an addition or alternative to insulin. So to conclude, hyperglycemia in pregnancy is associated with an increased risk of materno-fetal complications, and therefore optimized glycemic control is very important if you want safe outcomes. Insulin, of course, remains the gold standard in pregnancy. However, now we have data which is clearly showing that metformin may be safe except, like I told you, the contraindications, prematurity, SGA, uteroplacental insufficiency, or a tendency towards increased BMI in the various studies. So individualization is very important till we have more long-term data. Thank you so much.
Thank you, Dr. Shalini, for the exhaustive as well as the lucid presentation, but still sticking to your time. As she told, madam, you can, most of the European societies like ESC as well as ESD has approved glyburide and even glipizide for treatment in pregnancy in lieu of insulin. But the American guidelines, AD as well as FDA has not approved beyond metformin. So I think with the topic, both the topics, controversies in diabetes as well as oral medication for pregnancy is open for discussion.
And one thing I wanted to ask, see most of the patients, diabetic patients, they end up their 1 year of fast by strict dieting and all. So in post-pregnancy lactation mother, again, what are the drugs, anything, the same metformin and insulin, or do they have some relaxation?
Well, essentially, if you talk about recommendations, today the recommendation is only for metformin and insulin, but we are seeing, some people using SGLT2 inhibitors also in the lactation period. But like I showed you, there are studies that have shown that they are excreted in breast milk, so they should not be used. It is entirely off-label. As of today, on-label, legally, you can use only insulin or metformin during lactation. Once the lactation phase is over, you have the entire type 2 diabetes pathway to choose and give whatever drugs you want to give to your patient.
Excuse me. Yeah. Can I speak?
Yeah. Yes.
Dr. Shalini, thank you for that very lucid presentation. I have one question. Usually during pregnancy, you have respiratory alkalosis and compensatory metabolic acidosis. At what level of bicarbonate will you suggest that we shouldn't use metformin?
We should?
We should not use.
Obviously, if we are seeing any indication of acidosis, we should definitely stop metformin.
No, at what level? As a nephrologist, I am quite concerned about that. what
Is
level
there,
of
is there a
bicarbonate.
demarcation there? No, I am not aware of any demarcation, sir, with metformin, especially in pregnancy. Any high-risk pregnancy, any complication in pregnancy, metformin has to be stopped. Insulin is the only drug of choice which is safe because it does not cross placenta. Anything else crosses placenta. Absolutely, I agree. Sir, one thing is very clear. Any woman with CKD has to be on insulin. There's no even question of using metformin in CKD. In a woman who's planning a pregnancy.
Just to counter that, we all say that metformin should not be used when the GFR is, estimated GFR is less than 30 ml per minute.
Absolutely.
Now there is a new publication, good one from American Journal of Kidney Disease, that there were two groups. One group was using metformin, even with a GFR of less than 30 ml per minute, and the other group was placebo. And they found that cardiovascular risk and cardiovascular adverse effects were much lower in the group which were using metformin, even with a lower GFR of 30 ml per minute.
But were these pregnant women? This was a cohort of pregnant women. No, that's what. Pregnancy, definitely not. No metformin.
No, I think in metformin use, I think should not be used below a GFR of 45.
Absolutely, sir.
But if the patient is already taking metformin and maybe it can be used up to 30. If he is already taking metformin.
That is fine, but
otherwise
we are
for-
discussing
I'm not talking about
pregnancy
pregnancy.
today.
I'm not talking about pregnancy. The other thing, Shravla, I just want to say, we're talking so much about the HbA1c. I think we know that the HbA1c has limitations. For the same HbA1c, because of glycemic variability, I think you may have to probably do a CGM or a SMBG to just confirm. Because we know the glycemic variability can have identical HbA1c in two patients, one who is controlled, one who is not controlled.
Yeah, I said that at least in certain situations, we know all contraindications for HbA1c for reliance. Those are hemoglobinopathies, sickle cell, hemolytic anemias, and I mentioned pregnancy also, where you may not be able to rely on HbA1c. Even if you are relying on HbA1c, in pregnancy it has to be done every month. Ideally, you should do a CGMS to look for the glycemic variability. And what Sir said, he is right, that publication says that now there is evidence that even if you keep using metformin less than 30, even then it gets you the benefits. But that is only for patients, those who are non-pregnant. So it was not related to that. In pregnancy, it is clear that if patient has evidence of lactic acidosis, you should not use metformin. Unfortunately, again, this is part of the controversies. No pH value has been defined yet that at what pH you will stop metformin. It is by your clinical judgment that patient is on high dose metformin and dipping into, say, lactic acidosis, you should stop it. Those situations are more common if patient is having a febrile illness, patient has tissue hypoxia, patient has, say, impending respiratory failure, hepatic failure, renal failure, going for surgery, or on contrast where chances of lactic acidosis are more.
Thank you. Thank you, dear speakers and chairpersons.
Benefit is actually irrespective of the dose, 250 even in the low GFR conditions, because CKD is equivalent to CAD. So cardiovascular mortality can be reduced by small dosage of. So that's the thing. Regarding the metformin in pregnancy, in low resource countries like Africa and remote Asia, still where there is insulin initiation and the availability of the doctors are poor, metformin can be used even though insulin is the drug of choice.
Thank you. As we don't have much time, we are moving on to the next session. Thank you, dear speakers and chairpersons.